be there in person. I hope you can see my slides and hear me okay. So I was asked by Joe to talk about integrating new antiemetics into clinical practice. This is my disclosure. And so I thought in this 20 minutes that I'm allocated, I'll talk a few areas. So first of all, how do we integrate new antiemetics? Certainly, when new drugs come on board, we look at their pharmacology and look at its cost effectiveness, and then go through PNT. But one way is to really think about if there is evidence out there, and I think consensus guidelines is potentially one way to study the evidence. And then I'll talk a little bit about enhanced recovery and what is its role in reducing post-operative nausea and vomiting. Just review a few new antiemetics, not a lot, but most recently one, and in the last maybe 5-6 years or so, a couple more. And lastly, just presented with an algorithm on how does one think about managing post-operative nausea and vomiting. So just to bring back a little bit of history, this was our very dear journal. Dr. Schaefer was the previous editor-in-chief, and Dr. Pitet is the current one, Anesthesia and Analgesia. So this was back in 1914. It was actually published as part of American Journal of Surgery. It was published as a quarterly supplement. It always puzzles me when you look at the year here, 1914, right? And they still have AD stuck in front of the year. I guess wasn't quite sure whether they are in the before Christ era or after Christ era. I'm glad that we don't write AD 2021 these days. And also for those of you who I'm sure are very familiar, the journal or the society is coming up with a 100th year centenary celebration next year in Honolulu. So hopefully we'll see you all there. Now you will see that there was an article on prophylaxis of post-anesthetic vomiting. And obviously in those days, because with the use of ether, pretty much you can guarantee that most of the patient is going to be sick. So clearly that was a main problem then. But even if you look at today's incidence of post-operative nausea and vomiting, and although this was done almost 20 years ago or 12 years ago, but it is still a major issue. And you can see that the incidence of nausea and vomiting varies depending on the number of antiemetic prophylaxis that were administered. And clearly you can see from here is that the incidence of vomiting range from between about just under 10% to 30%. And the incidence of nausea range from about 30 to 50%, and depends on how many antiemetics that one prescribed. And about a third of these patients said that nausea and vomiting interfered with their functional recovery. So clearly it's still something that we have to grapple with on day-to-day practice. And even though this is over 10 years ago, but I can tell you that based on the data today, it really hasn't changed that much. So how does one assess the evidence of in this area of post-operative nausea and vomiting? I think one way is to look at what the evidence have been published. And it is daunting if you're trying to look at all the publication related to post-op nausea and vomiting. We have published 4 consensus guidelines over the years. First one was published in 2003. At that time, if you were to put in a PubMed on articles related to nausea and vomiting, we came up with just under 3,000 articles. And then the second consensus was published, in 2007. At that time, publication almost went up over 4,000. And in 2014, it was just under 8,000. And the one that we published last year there was well over 10,000 manuscripts in PubMed. So as you can see clearly, it is a daunting task trying to assess the evidence. And so this was the most recent update. It's the fourth one, and it was published last year in ANA. Was endorsed by over a number of professional organizations, not only in the US, but across the world. So just want to review some of the findings from the consensus guidelines. But the question always is that, if I were to have an algorithm or some sort of advising clinician what they should do the institution better off? In other words, have a lower incidence of nausea and vomiting at the institution? I think the overwhelming evidence is yes. If you, as an institution, have a guidelines and be compliant of the guidelines, and as this study showed that your incidence of nausea and vomiting will very likely go down. And in this case, you can see complete response rate was higher for those institutions who are compliant of the guidelines. So that is very clearly established. And we also know that in the last probably 20 years or so, enhanced recovery has really been looked at as a way to try to improve outcomes, and using a multidisciplinary approach and evidence approach. And this is just to tell you some of the elements of enhanced recovery. And clearly one of the main elements is prevention of nausea and vomiting. And in fact, for an enhanced recovery protocol to be successful, one needs to have a algorithm for prevention of postoperative nausea and vomiting, and not only to prevent the problem, but also to reduce potentially opioid use and other elements that would improve enhanced recovery. And this is a review article that we wrote recently, and really just to look at what are some of the elements within enhanced recovery that either directly or indirectly address the issue of postoperative nausea and vomiting. And again, you can see that on the column down here, there are many elements within enhanced recovery that addresses nausea and vomiting either directly or indirectly. From fasting, reduce the incidence of PONV, carbohydrate loading, minimally invasive surgery, so less opioid being used. Using Propofol as TIVA Propofol is a great antiemetics. Multimodal approach, regional techniques, reducing opioids, using a goal-directed fluid therapy. Not only we're able to not give too little or too much fluid, both of which can potentially increase PONV. So certainly there are many enhanced recovery. If I were to ask people to mute, that would be wonderful. And you can see that there are many elements that, in fact, directly or indirectly reduce post-op nausea and vomiting. And just to show you some evidence on shortened preoperative fasting and reduction in PONV. As you know, enhanced recovery now, we really don't advocate fasting from midnight. And certainly there's good evidence that giving fluids up to 2 hours, oral clear fluids up to 2 hours before surgery, not only improve comfort, but also reduce fluid requirement intraoperatively, reduce PONV as well. Now, the way that we usually, trying to decide which are antiemetics or how many antiemetics we use on patients, I think it's always good to know what the risk factors are, because just remember that every drug that we use always has side effects. If drugs has no side effects, we can always give as many as we can, but unfortunately that is not the case. So I still advocate the use of risk factors, and these are some of them outlining here. The larger the area, the more significant risk factors, and being female, opioid use, history of PONV are all important factors. And we also know that there are a number of receptors within the chemoreceptor trigger zone, which is an area that mediates nausea and vomiting. And therefore, if you were to use a drug that acts on one receptors, you are not going to be 100% successful. and therefore using combination antiemetics improve efficacy. Typically, we combine 2-3 drugs to maximize the efficacy, working on different receptors. Again, this is a group of pharmacologists. I don't need to go into details of these receptors, but the important thing is that there's certainly evidence to suggest that using multimodal antiemetics working on different receptors work better than single agent. And serotonin antagonist is probably in fact, the most widely used antiemetics, either in the US or across the world, because now Ondansetron is generic. It does work, albeit it's a little bit short in the half-life, 3 to 5 hours. And as over the years, there are other 5-HT3 antagonists came on the market, and most recent one is Palonosetron. I think getting its name from Palo Alto, which is where it was initially discovered. And again, you can see that the main difference is that it has a much longer half-life compared to Ondansetron and other earlier developed 5-HT3 antagonists. And there is some evidence to suggest that Palonosetron, with its longer half-life, may be more effective than Ondansetron, both in reducing the early and late nausea, and also similarly vomiting, which I didn't show here. But again, you can see that from studies, it seems to be more effective, mainly because I think it's longer half-life. Now, steroid is a very widely used antiemetics. It's not new, but I think it still has its main place in practice. And again, as you can see, there is no shortage of data here, over at least 50, 60 studies. And the recommended dose for prevention of PONV is 4 to 5 milligrams. In the US, it's usually come in 4 milligrams. And some other country, 5 milligrams, and number needed to treat is very respectable compared to other antiemetics. And in fact, if you actually use higher doses, 8 to 10 milligrams, there is also, again, plenty of evidence suggests that not only is it effective as an antiemetic, but it also can be used as an analgesic, reducing opioid requirement. And so I would certainly advocate the use of steroids, one dose. And there's always been concern about side effects, infections, avascular necrosis of femur, cancer causing. But again, there's been a lot of studies has been shown that one single dose does not increase this risk, but it does increase blood glucose transiently, typically about a few hours. And again, it doesn't stop me from using it, but I would monitor the blood glucose. There is a new study that was published, in fact, earlier this year by Tom Cochran and Paul Miles, a multi-center, over 8,000 patients, specifically investigating this question: does dexamethasone used as a single dose in during surgery affects or increase surgical site infection? And again, your surgeon always like to tell you that don't give you steroid, especially orthopedic surgeon, because it increases infection. So the bottom line is that it does not increase that risk. So you can see here, dexamethasone versus placebo, a huge number of patients, SSI at 30 days, no difference, 90 days, no difference, but certainly it reduces the PONV rate, as you can see here, and slightly higher hyperglycemic events, and quality of recovery was also better with dexamethasone. Interestingly, you also see that new onset chronic surgical post-surgical pain was a little bit higher, again, for a reason is still uncertain. But rest be assured that one single dose doesn't increase the risk of SSI. Another class which is really not new, but newer than the 5-HT3 is the NK1 antagonist. Preoperative is the only one on the market currently approved for PONV orally, but there is an IV version going to come on the market hopefully soon. And again, Preoperative is a good drug to prevent vomiting, and better than many other drugs. And you can see here is even better than Ondansetron in reducing vomiting, about 90% effective. So it is a good drug for preventing vomiting. Again, we all know that Propofol is an antiemetics. We have done studies in the past, defined the dose response relationship, and it's much lower than anesthetic dose and much lower than sedative dose. Again, there is no shortage of data. This is a meta-analysis of over 200 RCTs, over 20,000 patients. Again, if you look at PONV, pain score, I know that Dr. Flood also previously shown that PACU stay is reduced, patient satisfaction is higher. So great drugs for prevention of PONV. Now, there's one new drug that I'm just going to briefly talk about, and this is called Amisulpride. It is a dopamine antagonist. And in a way, it's not new because it is has been used for many years, probably over 30 years in the UK as an antipsychotic, but it's only available orally. Now, if you look at Amisulpride being a dopamine antagonist, we know that there are others like droperidol and haloperidol. There are a couple of different subclasses, and droperidol and haloperidol belongs to a subclass called butyrylphenone. And Amisulpride belongs to a subclass called substituted benzamide. And there are some subtle differences between the butyrylphenones and benzamide, in particular, sort of incidence or extrapyramidal side effects. And so the other difference between these drugs and some of the other drugs are that it is primarily excreted in the kidneys and not metabolized by the major cytochrome P450, and therefore lower incidence of drug interactions, and also plasma protein binding is relatively low, and again reducing the risk of protein binding. And the recommended doses is 5 milligrams for prophylaxis and 10 milligrams for treatment. And in fact, this is the only drug that has been FDA approved for treatment. Again, we use most of the drugs as treatment, but strictly speaking, they are not FDA approved. Just to quickly show you the data on prophylaxis as well as treatment. This is complete response. In other words, the higher the better. On the y-axis is probability of complete response, x-axis over 24 hours. And again, as previous speakers say, for this type of study, initially you need to compare with placebo. This is what FDA wanted. So there's no comparative data with another antiemetics, but in the combination therapy, so Amisulpride 5 milligrams together with another antiemetics, which typically was either Ondansetron or dexamethasone, fared better than placebo with another antiemetics. In treatment, again, compared to placebo, Amisulpride was statistically have a better effect compared to placebo, but so far we don't have a head-to-head study with another antiemetics yet. So in general, as I mentioned earlier, because PONV is multifactorial, and we know that giving one drug typically reduce the risk by about 25%. And it really doesn't matter which drug you use. Monotherapy reduce the risk 25%. Let's say if you have a baseline risk of 52%, go down to 37%. Adding a second drug reduce the risk by another 25% and so forth. So use or combination is advised. So the last couple of slides is to, how do one manage it? Well, first of all, I think there are things that we can do, what I call reducing baseline risk. And so, for example, avoid GA using regional. Propofol is a great drug, only to be used for TIVA, which has antiemetic effect. Avoid nitrous if you can do that, and minimize post-op opioid, intraoperative opioid, shorten the NPO status. And in fact, there is some evidence that using sugammadex instead of neostigmine also can reduce the risk of PONV, as shown here by a series of studies, because neostigmine obviously has a, being an anticholinesterase, has an effect on PONV. Algorithm, just to show you how does one manage. First of all, looking at risk factors, appropriate risk factors, provide antiemetics, reduce risk, as I talk about the baseline risk, and then give probably 2 or 3 antiemetics, and we recommend at least 2 antiemetics should be recommended in patient 1 or 2 risk factors. And for rescue, the principle is that if you had given ondansetron, don't give ondansetron again, at least within the 6 hours, where ondansetron is still working, switch to a different antiemetics. So what are the take-home messages? Well, unfortunately, it's still common and main cause of patient dissatisfaction. We know that PONV management strategy should be in every enhanced recovery protocol. The principles reduce baseline risk using combination antiemetics, at least 2 antiemetics, and then treat failure promptly and using a different class. With that, I want to thank you for your attention and pass you back to Joe. Thank you.
Great, TJ. Thank you. That was a very